we've always known that blood cancer care is expensive, whether that's pediatric, adult. But I think, and I really was pleased that ASH focused on this. They had a lot of sessions about access and cost, which usually that's the, poor redheaded stepchild. That's the health services research is not front and center. But at this ASH, it really was. And I think the biggest takeaway is, the degree to which this affects a family. The other children in the family, if there are, multiple children, that it can be generational. Those kids end up not being able to go to college because the entire family nest egg has been spent on trying to keep the child alive. And what parent wouldn't do that? Of course you would. You'd give anything. But it is overwhelming I guess the eye opener is the percentage of people that this impacts, that it isn't, we're not talking about the people who are, look, single moms, have to quit their jobs. This is all of us, other than the ultra wealthy. And I think it when you think about what there is to gain for a child, to be cured of their leukemia and ALL and kids has a very, very good response rate. Looking at that and worrying that families won't be able to afford that and therefore kids will not live. This is just, devastating. And it's the frustration that all of us have. We see it, we hear it from patients every day, and there isn't, if there was an easy solution, we would have done it. The issue is it's so multifactorial, right? Some of it, I mean, it's easy to say it's the cost of drugs, but that has been estimated to be 15% of the cost of care. And so, it's the cost of hospitalization. It's the cost of someone having, especially in pediatrics, one parent has to be at the hospital all the time. That means someone can't work. And now, with most families needing two salaries to be able to function, it also is an effect of what our economy is like right now. And, the inability for a family, we're not a 1950s Donna Reed family anymore. Mom can't stay home and wear an apron, or sit in the hospital. We need mom's salary. We need dad's salary. And so, what we have done is start several years ago a program we call Equity and Access. It's a research program. And what we're trying to do is not only look at what the problems are, but come up with potential solutions that we can test. And as those solutions are tested, if we think they're going to be effective, Blood Cancer United has a policy arm where we can advocate for that and we can bring that data to our lawmakers. Because I think the only way for this to be effectively changed is for our, Congress to help us not only with, I think everything to be done to look at the cost of drugs is important, pharmaceutical costs, but all the middlemen that are in, the procurement business, the hospital costs, the crazy insurance costs, and how the system is so complex. All parts of the ecosystem need to address the cost of care, and everyone's got to give a little bit. And that's not easy to make happen, but I'm hoping that some of our researchers in this particular program are focused more on potential solutions than just defining the problem. Individual lawmakers are hearing from their constituents. And one area in particular that we've played a large role in is medical debt, right? And as an advocacy organization, of course, we want to give people money to be able to help pay for their care. But, this is, sort of a need to not just throw money at it. This is a need to look at what's causing medical debt, what we can alleviate. Many hospitals have charity care programs that they don't tell patients about. There are legal and constitutional ways we can address that. And I think lawmakers are hearing enough about medical debt. We've had a lot of laws in states, little by little, sort of chipping away at, for instance, credit card debt for medical debt not being included on your credit rating, right? Because if it is, you can't get a job, you can't get a car. If you can't get a car, you can't get a job. If and it's an endless cycle for people who have medical debt. And medical debt is not, the same as buying a Ferrari, right? Look, if you've been profligate and you've used your credit card with money you don't have for buying things, that's a very different issue than having to use it to pay the $20,000 hospital bill. I believe lawmakers are, little by little understanding this. And I truly believe that this coming year, as we see people not being able to afford insurance on the exchange, which is going to happen because of the lack of renewal of the tax credits, and with people being forced off of Medicaid, we're going to have a huge number of people who are going to require charity care. And this is going to, it will break the system. And I think that lawmakers will have to attend to that because they're going to have a lot of constituents who are impacted. This year was much more about sort of important follow-up studies, and and this ties back into financial toxicity. There were some great myeloma presentations, with quadruplets, with, using CAR T earlier, with new CAR T, new types of CAR T, incredibly exciting. But just one myeloma drug can cost $16,000 a month. And while there's a cap for those who have Medicare, which is, we fought for, I think it's fantastic. That's not going to help the 60-year-old or the 62-year-old or the 57-year-old. And those are the people that have the most to gain, right?
Yeah.
The older you are, and I can say that,
Yeah.
I have the gray hair that allows me to say that. The older you are, the less time you have to gain from these innovations. The people who have the most to gain are the ones that are going to be able to ill afford these incredibly novel new therapies. And that, to me, breaks my heart because, I've been a researcher and a clinical developer all my life. And to think that we're developing things that people will not be able to receive, and that they'll receive inferior care because of cost. Um, I'm hoping this ASH was a wake-up call. I think that there is much we can do to try and alleviate the high prices. Um, but again, that isn't going to, by itself isn't going to solve the problem. So I think I applaud the work that's being done to try and negotiate, especially the highest priced therapies. But the cost of administering those therapies, the cost of the pharmacy benefit manager, there's a lot of pieces that go into why that is so expensive for the patient. And unfortunately, the system um, has protection for the pharma companies, protection for the insurance companies, protection for the pharmacists and the pharmacy benefit managers. But no one is actually protecting the patient. And that, I think, is where we all have to look and say, what could we do as as a healthcare industry to chip away at this? And I think we have to. And at some point, it will impact sales of drugs, right? Because, if patients can't afford it, they're going to go without. And, um, and that will eventually, wreak havoc on, the profits that pharma will be able to make. If people can't afford CAR T, even though that might be the best therapy for them, they're not, they're going to get something else. And it will eventually mean less use of the most promising therapies that companies are developing. And so it behooves all of us to start chipping away at this and saying, what can we do to be a solution? Part of the solution instead of just part of the problem.